Today, FDA approvals in ovarian cancer, Merkel cell carcinoma, immune thrombocytopenia, and of a biosimilar, and a European approval in melanoma. Welcome to Enclave News Network. I'm Gina Columbus. The FDA has approved olaparib as a maintenance treatment for patients with deleterious or suspected deleterious, germline or somatic, BRCA-mutated advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to frontline platinum-based chemotherapy. This is the first approval for a PARP inhibitor in the first-line maintenance setting. The agency also approved BRCAnalysis CDx, a companion diagnostic assay, to be used by healthcare professionals to identify patients with advanced ovarian cancer with a germline BRCA mutation and are eligible for first-line maintenance therapy with olaparib in this setting. The olaparib approval is based on findings from the Phase 3 SOLO-1 trial in which olaparib reduced the risk of disease progression or death by 70% in patients with BRCA mutant advanced ovarian cancer who were in complete or partial response to platinum-based chemotherapy compared with placebo following platinum-based chemotherapy. The safety profile of olaparib was consistent with previous trials. Additionally, at a median follow-up of 41 months, the median progression-free survival by independent central review was not reached in the olaparib arm versus 14.1 months in the placebo arm. The investigator-assessed PFS in the olaparib arm was not reached versus 13.8 months in the placebo arm. The median PFS for olaparib has not yet been reached. In Merkel cell carcinoma, the FDA has granted an accelerated approval to pembrolizumab for the treatment of adult and pediatric patients with recurrent, locally advanced, or metastatic disease. The approval was based on the Phase 2 CITN-09 KEYNOTE-017 trial, which showed that pembrolizumab elicited an overall response rate per independent review of 56%, as well as a 24% complete response rate and a 32% partial response rate in patients who did not previously receive systemic therapy. In the multi-center single-arm open-label trial, 50 treatment-naive patients with recurrent, locally advanced, or metastatic MCC received pembrolizumab at 200 milligrams per kilogram every 3 weeks. At a median follow-up of 14.9 months, results showed that the median duration of response was not reached. Among the 28 patients with responses, 96% had a DOR greater than 6 months, and 54% had a DOR greater than 12 months. Moreover, the median PFS was 16.8 months with pembrolizumab, while the median OS had not been reached. The accelerated approval of pembrolizumab in this setting is contingent on the results of a confirmatory trial. The FDA has approved romiplastim for the treatment of pediatric patients at least 1 year of age with immune thrombocytopenia for at least 6 months who have had an insufficient response to corticosteroids, immunoglobulins, or splenectomy. The approval is based on 2 double-blind placebo-controlled trials, the first of which randomized 62 patients with relapsed refractory disease following at least 1 previous ITP treatment in a 2-to-1 ratio to either romiplastim or placebo. 52% of patients in the romiplastim arm achieved durable platelet response compared with 10% of the placebo arm. 71% versus 20% of patients in the 2 arms had an overall platelet response. In the second trial, 22 patients were randomized in a 3-to-1 ratio to romiplastim or placebo. In the romiplastim group, 88% of patients during the treatment period reached a platelet count for 2 consecutive weeks and an increase in platelet count of above baseline for 2 consecutive weeks. Neither outcome measure was reached by any patient treated with placebo. Overall, romiplastim was well tolerated. 3% of patients discontinued treatment because of adverse events. The FDA has granted an approval to the trastuzumab biosimilar CTP6, known as Herzuma, for the treatment of patients with HER2 overexpressing breast cancer. The biosimilar is indicated for patients with adjuvant HER2 overexpressing node-positive or negative breast cancer to be used as part of a treatment regimen comprised of doxorubicin, cyclophosphamide, and either paclitaxel or docetaxel, or as part of a regimen with docetaxel and carboplatin. The biosimilar is also indicated as first-line treatment for patients with HER2 overexpressing metastatic breast cancer to be used in combination with paclitaxel or as a single agent to treat HER2-positive breast cancer in those who have received 1 or more chemotherapy regimens for metastatic disease. The decision is based on an extensive review of a comprehensive data package, which included foundational analytical similarity data, non-clinical data, clinical pharmacology, immunogenicity, clinical efficacy, and safety data. Additionally, 2-year follow-up findings from a double-blind randomized Phase 3 trial with CTP6 demonstrated that the biosimilar demonstrated long-term disease-free survival and overall survival that were similar to trastuzumab in the treatment of patients with HER2-positive early breast cancer. In melanoma, the European Commission approved pembrolizumab as an adjuvant therapy for patients with resected stage 3 disease with lymph node involvement. The approval was based on data from the Phase 3 EORTC 1325MG KEYNOTE-054 trial. For its review, the European Medicines Agencies requested an updated recurrence-free survival analysis with 7 months of additional follow-up beyond the trial's initial data cutoff. In this analysis, pembrolizumab reduced the risk of disease recurrence or death by 44% versus placebo in patients with resected high-risk stage 3 melanoma. The 1-year RFS rates were 76% versus 61%, and the 18-month rates were 72% versus 54%, respectively. In the United States, the FDA is currently evaluating a supplemental biologics license application for pembrolizumab in this setting based on the previously reported data from the EORTC 1325MG KEYNOTE-054 trial. In this earlier analysis, adjuvant pembrolizumab reduced the risk of recurrence or death by 43% in patients with resected high-risk stage 3 disease. At a median follow-up of 15 months, the 1-year RFS rate was 75.4% with the PD-1 inhibitor versus 61.0% with placebo. The RFS benefit was observed regardless of PD-L1 or BRAF mutation status. This week, we sat down with Dr. David Maloney of Fred Hutchinson Cancer Research Center to discuss post-CAR T-cell therapy infusion care and transitioning to outpatient.
So most patients receiving axicabtagene ciloleucel will require that the 3 mg be given in the hospital. We do not attempt to administer this product in the outpatient setting, and if you did, you would have to admit the patients immediately thereafter for monitoring for cytokine release syndrome and neurologic toxicity. In general, patients are in the hospital between 7 and 14 days. Minimum is generally suggested to be 7 days. In my experience, it's closer to 14 days for nearly all patients. Other products, though, do not necessarily have to be given in the hospital, and there is not a requirement for inpatient administration with the tisagenlecleucel or the new clinical trials agent lisocabtagene maraleucel, where we have more experience in the outpatient setting. So patients, while they're in the hospital, require intensive monitoring on general ward first, and then if they become unstable and develop significant cytokine release syndrome, at least grade 2, then most patients will require ICU care to monitor them for those symptoms. This requires very close coordination between all the people that are participating in the care of the patient. That includes the nurses, the providers, the physicians, as well as the ICU staff and physicians. And this is a requirement of the REMS programs for both products, and these require extensive training of multiple people involved. At our center, this was over 350 people required to become REMS trained to be able to give the commercial products. This is a big deal, and it is a cost to your institution to provide all of this training to be able to provide this product. Patients are in the hospital until resolution of symptoms. If they were outpatient, then they get admitted at the first sign of symptoms and then are monitored in the hospital until essentially resolution of those symptoms, and then they're discharged back to an outpatient care. They have varying levels of required care at that point. It could be daily, coming in daily for count checks if they're still having a persistent thrombocytopenia or pancytopenia. Most patients do have significant count suppression and need for platelet and red cell transfusions during this whole period of time. And in about 20% of patients, this can persist for weeks to months after treatment. And that has to be managed in the outpatient setting, generally before discharging the patient back to their local oncologist. These factors it's very critical that these patients are monitored inpatient and outpatient for these toxicities. And when patients develop cytokine release syndrome, they can develop other organ toxicity. Coagulopathy is common, and patients need to be monitored for this and aggressively transfused to prevent bleeding complications. And this needs to be done either in the inpatient and the outpatient setting, depending on how sick the patient is. In most cases, patients in the outpatient setting will require a caregiver to be with them essentially 24/7 if they're not in the hospital in that first 30 days or so, because patients can develop the onset of cytokine release syndrome or an infection in kind of a critical, urgent situation where they may or may not be able to make their own decisions and notify healthcare providers.
That's all for today. Thank you for watching Enclave News Network. I'm Gina Columbus.